So do you think if you have a patient who say has been sent to you, it's been a few weeks since the radiation, or you're looking at it, it looks like some pretty hard looking bone in there, you think you go ahead and grab that drill?
Yeah, that's when I think about it. I think hard about grabbing the drill right off the bat so that I don't make everybody uncomfortable.
Right. Right.
Was it fun? Absolutely. that was a very fun day to be doing that case.
Yeah.
And everybody in the cath lab, their eyes were about this big. Like, what are you doing? I said, no, just trust me.
Just drilling. Yeah, exactly. So we've talked about a lot of great tips, and one thing I want to know is your process of watching cement. What are the things that you look for when trying to stay safe, but also trying to maximize the amount of cement you can put in?
That is a great question, and this is one of the art of medicine type of things. The device that I use has a little hand pump so that I can stand way back and watch while it's going in so I don't irradiate myself as much. But what I will do is just pump very lightly and quick, very short, very quick pumps as it's going in. And the main place where you don't want it to go is out the back, because that's the dangerous spot. That's the danger zone. Having it go out through the back of the vertebral body is bad news for everybody. So you want to watch for the basovertebral flexus filling with cement. If that fills with cement, stop, disconnect the cement from the from the cannula. That is the only way to absolutely relieve all the pressure on it, to make sure that you're not maintaining a pressurized system. And then wait. Take sure of time, let that cement harden, because it's always going to follow the course of least resistance. The path of least resistance is where the cement's going to go. So you just want to make sure that it forms a different path of least resistance than the one that it's going on that you don't like. And the way you do that is either wait for the cement to harden or reposition. And whichever one you choose to do that, as long as you do it within the working time of your cement, you have not created any issues for anyone. Especially if you're confident that you've gotten the right spot, then just sit and wait. If you're not feeling the fracture line, move until you are going to feel the fracture line, and then start injecting. And just make sure that it's not going too far backward. If it's going too far backward, pause, take a look, wait and see what's going on, flip around and see what you're doing, see where everything is going. I have not had good luck with the eggshell technique.
Yeah, tell us a little bit about that. I've been curious about it. I haven't used it myself.
The eggshell technique is ostensibly you've created your cavity with your balloon. You put a little bit of cement in, then you stick your balloon back in, blow it up, and let the cement harden around it, so that you have created a safe fill zone for you to fill with cement. The problem with that is a little tricky, because you don't want to glue the balloon in the patient, and raise your hand if you've done that. And you don't want to, if you pull it out too soon, then the cement just kind of flops around and doesn't do anything. If you pull it out too late, you glue the balloon in the patient, and you have to, tug it out and pull that out. And almost always the balloon pops.
Yeah, that's almost a foregone conclusion in that. So,
because the cement heats up and just it has a chemical reaction with the balloon and it pops. So now you've got contrast all over the place. I've tried it and never had good luck with it. I think I may just not have been patient enough to do it and let it work, but
it sounds like a tricky technique. It sounds like one of these things that very useful in theory, but as the saying goes, in theory, there's no difference between theory and practice. In practice, there is. And that's one of the things. And I found that I think that's a cool idea, but I found that just being willing to redirect your cannula goes a long way towards getting the cement fill that you need to do without causing any issues. And as you said, when it comes to posterior, it's really that basivertebral plexus, kind of that little reverse flame-shaped thing that you see on the MRI if you actually look at that part, and also lines up with the basivertebral nerve, which talked about at length. That's the primary egress for the cement posteriorly. So it seems that this notion that some people say, oh, the cement's started to go posterior, abort, just call it off, yank the cannulas out.
Wave off, yank everything out. No. Don't do that.
Yeah, no. Don't do that. And so going posterior, I don't know where this myth started, but it is a myth. It's not true that if you start to feel the posterior third, you have to just stop and whatever. That's not true. So you have to look for that basivertebral plexus filling. And what I really like about that, when I see that, I'm like, awesome. Because I know that wait for a minute, let that harden up, and then you're pretty well protected from it going out into the ventroepidural space. You still got to keep an eye on it, but I like when, you've plugged that main egress and then you're kind of like, okay, sweet.
With the caveat that if they have a fracture line going through the posterior wall, then they've got another place of egress that you need to keep your eye on.
Exactly. So you really have to, I would say just constantly be monitoring, it's like when you're driving, you're focusing on different things and your eyes go between. And so you need to monitor the anterior cortex and the posterior cortex and look for those telltale signs. And the other thing is when you actually start to get a fill in the ventroepidural space. And this is something that's happened to all of us. And I will say probably 99.9% of the time it's asymptomatic and it's not of clinical concern. And personally, when I dictate my reports on a kyphoplasty, or if I'm looking at an imaging study on a follow-up, I am brutally objective describing all these things. And I think it's important to know that, there is the possibility of that happening, of getting some cement in the epidural space. If that happens, same as if you're feeling the plexus, just take all the pressure off. Don't inject anymore. The cases that I've seen that have been really bad is when people didn't recognize it and they just kept pumping it. And then you end up with severe stenosis, and that's a major issue. So one thing I'll say is always know the patient's degree of stenosis at the fracture levels you're doing. If they have pre-existing stenosis, just be aware of it, and don't go adding to it. But a patient who has mild or no real stenosis, you don't need to worry about if a little bit of cement goes into the ventroepidural space. Almost always that's going to be asymptomatic. That doesn't mean do it with impunity. That's not what I'm saying at all. But sometimes you will start to see that little lenticular shape. You'll just start to see it fill mostly along the contour of the posterior cortex, and just stop.